department. I'm director of the Psychological and Forensic Assessment Services here. And rather than talk much about who I am, let's talk about what I'm going to talk about today, which is a really, I think, interesting and very current topic in psychiatry. It's a kind of a joy for me as an assessment-based psychologist to sort of see this, the use of psychological assessment start to become mainstream in psychiatric care. So that's what we're going to argue for. In fact, there's a fair amount of literature on that. And the thing that's nice is a lot of it's easy, much of it's free, and I'm going to give you a lot of links to where you can get the stuff for free or not a lot of money, and you can bill for it. You can bill for psychological testing if you are a family physician, and family physicians regularly charge that service when they come in and they do an intake and give a BEC or something like that, and they actually charge for it, and so it's compensable, which is important these days. And it's always important when you start doing this to have some kind of relationship to an assessment-based either psychiatrist or psychologist, because there's a literature behind this, and these can be, and I'll talk about how they can be used well and misused badly. So I'm disclosing financial, I'm talking about assessment. I have author of 2 assessment books, and not ones we're going to emphasize today, but a little bit, and those are them, and that's my conflict of interest. So what is management-based care? How many people use management-based care regularly in their practice? You do. I know you do. Okay. So, interesting. Okay. It's the practice of using routine symptom measurement or more to inform diagnosis and treatment. It's an evidence-based framework that has established effectiveness, broad reach, and multifaceted utility, enhancing care. And this is this article below is a 2015 article. It's a really good place to kind of get an overview. And I'm going to give you some of the main points from that article, but it's just such an excellent resource that I recommend it to you. There's very good literature to show medium effect size improvements with depressed patient outcome over usual care, even using an evidence-based CBT protocol. So there's a value added, there's incremental validity to evidence-based treatment by using measurement-based care. And it's particularly effective in improving outcomes where depressed patients are not demonstrating project or by reducing patient deterioration. So it's not just good at care, but it's also a nice safety net. And besides its use in CBT, it can involve multi-theory specific components targeted at single disorders, and it's trans-theoretical, relevant for the use of clinicians regardless of background, and trans-diagnostic, in which it's, the main work has been, as you would imagine, coming out of the work of John Rush, has been with depression, but it can be, I'm going to show you some other applications of it as well. And so by monitoring outcomes, you then satisfy meaningful use requirements, which is going to be requirements in the Patient Protection and Affordability Care Act if we have it. We'll see. We should know in a few months where we are on that. And it presents a systematic approach to selecting and adapting interventions by flagging patients who are not improving, and it helps highlight treatment goals. So, not all depressions and anxiety disorders and PTSD, as we'll talk about, are created equal. Under the new criteria to meet the minimum requirements for PTSD, which is stressor requirement, the adequate number of the 4 symptom clusters, how many combinations and permutations would that create? Just kind of calculate that in your mind, okay? It's about 600,000. And so to say somebody has PTSD is not that helpful. What we can do with evidence-based care, we can take a look at the particulars of that disorder and actually target it. Is it more in the hyper-reactivity area? Is it more in the avoidance cluster? Is it in that and that? And so it allows you to really focus in your care by understanding not that just the person has the disorder, but the real specific components of it. And yet, less than 20% of psychiatrists, psychologists, social workers, and counselors routinely use readily available and free or inexpensive, that should say, measurement of mental health status and treatment of their client. The exception to this rule is the VA. The VA has been using measurement-based care for quite a while. People are screened regularly on depression, PTSD, and a variety of other alcohol use disorder, substance abuse disorder, and that sort of thing. It's just part of the regular requirements of primary care in the VA, and so the VA is fairly advanced on this. So what can it do? What can measurement-based care do? It can optimize accuracy and promptness of diagnosis and management, and using measure and focusing on treatments using psychometrically sound measures. Specific treatment plans that are targeted to the individual. Regular evidence-based progress assessment allows you to kind of become flexible in mid-course. If you're doing a particular model of CBT and you're emphasizing certain elements, and you find out through your measurement-based care that actually there's no real symptom change, then you know that it might be a good thing to kind of flexibly move, or things get worse, which happens. And collaboration between the clinician and patient increases joint implementation, assessment, and revising of treatment goals. It's a way to get get in your client's shoes and to get on the same page together. And this other article in 2011, which I highly recommend, recommends management-based care as a standard of care in mental health care. Very interesting. That's a pretty powerful recommendation, and that's very well documented why that should be. So what are some of the problems with management-based care? It can be an excessive and overly long assessments can be burdensome, and so you want to be able to know the range of things that you can do so that you can target. You know, it used to be everybody got a full psych assessment, okay? And it's kind of throwing it up against the wall and seeing what you got. I don't think we're at that place anymore in our development. Certainly not in psychology and psychological assessment, but I think so also in psychiatry. There's a concern that these measures can be depersonalizing if the clinician is too focused on measures and rather than using measures as a way of connecting with the patient. And measurement without an action plan may be unhelpful. And that's really my gripe about a lot of the psych assessments that I see, or use of these things, is that they're done, but there's no real clear sense of what the connection between the measurement and what the specific outcome that you'd like to have. So let's kind of go through. What I'd like to do is I kind of like to take you through kind of a little tour of psychological assessment methods so that we can take a look at what might be useful. At the very basic level, we have basic symptom screens, which I call mono methods. Okay? They're very targeted, very specific, and they have really great, I think this sort of thing ought to be used in primary care, actually, not just psychiatry. But of course, we have the PHQ-9, which I think a number of the folks in the psychiatry department use regularly. Terrific. I think every primary care doctor ought to give the PHQ-9. I think in the VA, the PHQ-2 is given, and if there's any indication positively, it's automatic. PHQ-9 is automatically given, and that's in primary care settings. It's not just in psychiatry. One that's, I think, underused is a generalized anxiety disorder scale, which is a 7-item screen that's very good for diagnosing GED, and also lets us know that there's a problem. It can also pick up panic disorder, social anxiety disorder, and more modestly PTSD. As you can see, these are non-specific measures. And so that's one of the things. So if you get a PHQ-9, do you automatically get a diagnosis of major depressive disorder? Absolutely not. It's sensitive but not specific. So you think about screens as case-finding methods, ways of including, and then that's when your psychiatric or psychological interview, psychosocial interview, helps weed out what this kind of general distress that kind of looks like depression or kind of looks like anxiety or kind of looks like PTSD looks like. And then there's a primary care PTSD screen, which is the PTSD-5. It's a 5-item screen that is used primarily. If you get it positively, there's about, there's about a 60% chance that the person will have a diagnosis of PTSD, but it's not necessary. It just says to you, you need to look further. There's a kind of a warning light that goes on and says, look here. They're not used diagnostically, and that's really can't be done except for an interview. The advantages is that they're evidence-based. They can be used in assessment and monitoring. They're free and available online. Just put any of those measures on and you'll go to a page and they'll have a PDF. You print it out and you use it. They're seen as public health measures. And they have pretty good sensitivity, high sensitivity actually, for case inclusion for the screen of a possible disorder. Mono methods are not comprehensive. So somebody comes up really high on the PHQ-9. What doesn't that tell us? What's another area of real concern, of a pretty serious mental disorder that is going to pick that up? What's that? Rape? Grief. Okay, it could be grief. Bipolar, one piece of the bipolar. Okay, think outside of the axis formerly known as 1. What has a very, very high comorbidity with depressive disorder symptoms? Absolutely. Which one in particular might we really be interested in knowing about? Borderline. Borderline. The comorbidity of major depressive disorder and borderline personality disorder is very high. People who have borderline personality disorder are miserable and distressed. And so if we simply treat the depression and we don't look at the character structure underneath of it, we can be kind of pounding sand down the wrong rat hole. So the low specificity, as I was saying, but it does not emblematic of the disorder. It doesn't tell the disorder. Self-disclosure is also always, when you're using self-disclosure methods, you're going to hear me say this over and over again, it is limited by the patient's self-awareness and their willingness to disclose. So when somebody says, do I have this symptom or not, they either may not be aware of it, or they may say, well, I'm not going to let him know because I don't trust the guy or gal. Okay? It's just two little ways of thinking about that. And negative symptoms are not, negative findings are not definitive of rule-outs. Okay? And if for no other reason as the person might not want to disclose it. It's symptom-based, so it doesn't place findings in the overall context of a person's life, which can only really be gotten through interview. So let's talk about some basic symptom methods that are either very inexpensive or free. And the two that come to mind immediately are the Beck Depression Inventory, the BDI-2. I always like that BDI, you know. And anyway, and the HAM-D, the Hamilton Depression Rating Scale. And they're pretty similar. I happen to like the Beck better. I like the psychometrics on the Beck better. But you have to pay, I think, about $3 if you buy them in bulk to use them. But pretty valuable. The Hamilton D is free and online, and there's your link to get it, and here's the link to order it. And there are lots of other depression inventories. These are my two favorite. These have the most literature. They're the best used, so why not use them? Advantages, again, they're evidence-based. The HAM-D is free. Good sensitivity and decent specificity. So if you get PHQ-9 that's positive, following up with a Beck Depression Inventory automatically increases your specificity. And it's more fine-grained, and it includes associative phenomena. Take a look. It's 21 items as opposed to 9 for both the HAM-D and the Beck. That, like a lot of basic measures, it's not comprehensive. The limitations of self-report, negative findings don't rule out, and it, again, it has all the disadvantages of the others. Only this is like better. So if you get a screen, if up front the secretary gets a screen of that's positive on the PHQ-9, you could automatically, if you decided to set up a procedure, have that person fill out a Beck or a HAM-D. And then you're already starting your interview with a lot more information than you did when you didn't, for very little energy. Like with depression, there are really nice symptom methods. There's, of course, the Beck Anxiety Inventory, very similar to the Beck Depression Inventory. And then one that's really kind of interesting, that's not used as much, that I like, which is the State Trait Anxiety Inventory, which not only looks like anxiety, it looks like what's called state anxiety, is I'm tense, I'm worried, as opposed to trait anxiety, I worry too much over something that doesn't matter. And there you start to look at kind of sort of axis 1-y sorts of things, and then more chronic. And of course, dealing with somebody that's currently tense but doesn't have high state anxiety is a different animal than somebody that has high state anxiety. It's going to require a different kind of method. Again, pretty much the same in terms of advantages and disadvantages. So one of my favorite areas of work is assessment and treatment of PTSD. And we have and this again is a free instrument. Here's your link to go get it for free. So it's not going to cost you anything. You may be able to charge for it, but it won't cost you to administer it. And it's basically assesses the absence and presence and severity of the 20 DSM-5 symptoms for PTSD. And it's best used, and this is really important, with Criteria A designation and life events checklist. The particular reason for that is that there's a really good set of studies showing that the PTSD checklist will elevate for non-Criteria A stressor events. So if somebody's undergoing a divorce or is in the process of losing their house, or they've defaulted on their mortgage, or other very powerful life events that will not code for PTSD, no matter how much you think that stress is traumatic. It is not PTSD as diagnosed in the DSM. It's one of the single most overdiagnosed and misunderstood disorders that I think is out there right now, because everybody's on the trauma bandwagon. and I had an argument with my boyfriend or girlfriend, and it was really traumatic. Is that a stress? Is that going to be PTSD? Does that meet stressor A criteria? Well, maybe. And he beat me, or she beat me. Okay, nearly, we're getting there to an inch of my life. Now we're really there. But you can't get it just from the symptoms alone. That's very important in using that instrument. And so there's some associated items that you can use with that will increase the specificity of the disorder. There's another one called the Edna Foa's Post-Traumatic Diagnostic Scale, which is currently, she had one that was used for DSM-4, and it's currently in development. It's about as good. It's not free. And so I like the PTSD checklist with the particular caveats that I've given you. It also talks about distress and interference items, and so it also takes a look at the criteria for are you distressed by these symptoms, and are they interfering with work and social functioning? So, which is, again, required for the diagnosis of PTSD. Very similar advantages with PTSD in particular. The particular configuration of those 4 symptom clusters is really central in focusing your treatment. If you got somebody that's super high on avoidance and super high on hyper arousal symptoms, and you hit them with exposure methods, in my opinion, you may be engaging in a bridge too far. You may want to get those hyperarousal symptoms better under control and begin to help that person understand the cost of avoidance before you come back and you rework and help them work through the stressor itself. That's just one simple example. The PCL-5 has really poor specificity in the research. It really is almost a measure of general distress. So you have to, when you get a positive finding there, you have to kind of keep in your mind that that's the case. A person could have a trauma exposure and have these symptoms, but it may be not because of the combat experience that they had, but because their marriage is breaking up and they're having a mortgage. So you've got to really use your interview to take a look to make sure that that diagnosis is accurate. And that's the problem with the specificity issue with the PCL. Okay, now I'd like to talk a little bit about the advantage of structured interviews. I really like structured interviews, particularly early in practice. And my favorite one, and I think one of the really truly great teaching tools, is the SCID for 5, the Structured Clinical Interview for DSM clinician version. How many people have ever used a SCID? Okay. The use of the SCID, from the time that you use it until about you have about 20 to 50 under your belt, will increase dramatically your capacity to hold in your mind alternative diagnoses, because there's a lot of overlap in the diagnostic criteria. Let's just take 3: PTSD, anxiety, and depression. There are a significant number of overlapping symptoms in those. And what I saw, and I'll tell a story, for a number of years I was a comp and pension examiner for the VA, which is disability in the federal system. And I read, in addition to doing the assessment and the interview, and I did testing, I had to read notes. And I got to the point that when I got to the record, and a particular psychiatrist that I knew at the VA I worked was there, I said, oh, okay, this is going to be PTSD and bipolar disorder. And sure enough, it was, even though the testing really didn't show that. That's because, and I'm sure if you looked at my records, you'd begin to see a kind of consistency. We get into a habit. It's, kind of Kahneman's thinking fast and slow. We tend to arrive at judgments most of the time very quickly. They don't tend to be very logical, but they tend to work. Thinking slow is really going through systematically and slowing down and working on the details. That's where you get your accuracy. And thinking slow in diagnosis is a really good thing. So basically, it's a decision tree model where you start with it's a structured interview. It starts at a particular place. You'll have certain rule-ins and rule-outs, and you'll follow the decision tree, and you'll do the symptoms, and at the end, you're going to get it's going to be a very high likelihood, way higher than general interviewing. It's going to be far more accurate at specifically diagnosing disorders according to the DSM-5, if that's of interest. Another one is the SCID for personality disorders, the same format for what I like to call the disorders formerly known as Axis 2. And there are others, if you're into a specific area, there's a wonderful dissociative disorders structured interview. There's the clinician-administered PTSD scale, which is the absolute gold standard for the assessment of PTSD, which is free and available online at the National Center for PTSD. You have to apply to get it, and then they send you the material, including a manual and things like that. And you can really find, if you're working with somebody with complex and severe PTSD, it allows you early on to really target symptoms and begin to sort out what's what. I love it. I mean, in the VA, I had known it so well, but I just did it. I didn't have to have the structured thing. I just knew it, and having done it, 2,000 times. And it really, really helped me get clear. And there are other personality disorders. There's a psychiatric research interview for substance and called mental disorders called the PRISM that comes out of Columbia University, which I think in some ways is better than the SCID, but SCID is more available, and I think it's the one I want to recommend. These are evidence-based measures with good psychometrics. They're evidence-based and substantially increased diagnostic accuracy, which then can result in more focused treatment. We're going to don't have to noodle around quite as much. It's focused on increased symptom specificity for the treatment focus, and comprehensive and controls for clinician bias. And it's an excellent training tool, and the research on these methods are really high. They're really good quality evidence. This one is time-consuming. A SCID takes, would you say, about 45 minutes, half an hour in an uncomplicated case, 45 minutes maybe in a complicated case. Add the SCID for PD, and you're talking about some time. It can also, unless you develop a kind of casual way to do it, it can be seen as kind of mechanical. But then again, that's something that I think all resident psychiatrists and clinical psychologists struggle with anyway, which is being too tied to their instrument and not and learning how to develop it in a more client-centered, focused way. It requires some training, and they don't have validity scales. And that's important in your areas where there's high base rate for underreporting of symptoms or overreporting symptoms, or even feigning symptoms or malingering, such as you would find in any kind of disability evaluation, where the rates of exaggeration are somewhere between 30 and 50%, high because of the secondary gain. I want to introduce you, if you are interested in working with personality disordered clients, in psychotherapy and maybe even in medically, I would like to introduce you something called the SWAP. And that's a clinician-completed measure that systematically assesses for personality disorder diagnosis. So basically what you do is that you give a specific interview or you see the client 5 times. And then you sit down on the computer with the SWAP and it asks you questions. Is it more likely that this symptom fits this client or less likely? And I think it's on a Likert scale. And at the end of the 25 to 35 minutes, you get a really accurate diagnosis of personality disorder based on your clinical judgment. You don't have to worry about asking the client. This is based on your professional trained observation. This is a really terrific method. If you're interested in doing comprehensive longer-term treatment with personality disordered clients, which is the sort of standard, brief therapy for borderline personality disorder is probably an oxymoron, okay? And the advantages are quite simple. Again, the increase of specificity for treatment focus. It also, because personality disorders are so powerful at eliciting countertransference in the clinician, it helps to control for that countertransference, which I think is a real advantage. It's a very highly researched, it's got hundreds of peer-reviewed articles talking about its capacity to work well. It's not so good for rapid diagnosis and medication management. It's expensive in terms of time. It's not handing somebody a 21-item interview. Yeah? I think you can. I don't see any reason why not. I think the secret is that, now what's that code? No, I don't think you do that code. You want to use psychological assessment, a psychological assessment testing code. And that's not, it's sort of like a psychiatric interview, initial interview. Mental health people that are not psychiatrists can bill that code, and there's no reason why psychiatrists can't bill that code, or social workers and things like that. It's being done regularly these days, so that's the information I have. Now this one also is a measure. The SWAP requires training and some pretty significant experience. This is more for a kind of early, late early intermediate level person who has some knowledge of what personality disorders look like. So it's not kind of like the SCID in that it's a paint by the numbers. It really is. This one really requires some more clinical judgment, and experience is helpful in that. Oops, that's what. So no discussion like this would be complete without a talk about what I call the Omnibus multi-symptom methods. And these are there are 3 biggies in the field: the MMPI, the Personality Assessment Inventory, and the Milan Clinical Multi-Axial Inventory. And what these do are using fairly highly sophisticated psychometrics within 30 to 45 minutes to an hour. You can get a picture of a client's symptom picture that you will never get in an interview. There is no way for you to keep in your mind 200 to 300 variables all at the same time. It's just not possible. Actually, I think it was Miller who wrote back in the late 50s or early 60s the rule of 7 plus or minus 2, which is the number of conscious variables we can hold in our head in the same time. Okay, so when you're experience, then you're going to have a lot more implicit variables sitting in the background. But we can kind of keep 7 things in our mind, 7 possibilities in our mind at about the same time. 9 if we're having a really good day, and 5 if we're like, sleep deprived or something like that. The MMPI is the sort of the grandfather of these. It's a terrific instrument. It really requires, for a variety of reasons, it's not a simple instrument. Even though you get a printout, it is not a simple instrument to interpret. So if you have somebody with PTSD, what's the high scale going to look like? It's going to be the schizophrenia scale. It'll be 2-8, depression and schizophrenia, or 2-7-8, depression, anxiety, and schizophrenia. And so you have an anxious, depressed, psychotic person. Well, that's not, PTSD isn't an anxious, depressed, psychotic person. It's an anxious, depressed person with a variety of unusual experiences, like flashbacks, if a rare but powerful symptom, but also intrusive memories and bad nightmares and things like that. Sense of confusion about what's going on in the real world and because of the triggers that kind of dominate the person's life. But this has a massive research base. When I was doing this about 3 weeks ago, I went on to Psychlit and just put in MMPI, and I got 13,905 hits and nearly 10,000 in peer-reviewed journals. That's a lot of research. And the personality assessment inventory is a newer one, which kind of takes the best of the MMPI and gets rid of the worst psychometric features. This is a much easier one if you're a non-psychologist. This is a much easier instrument to learn. And it's my hope that one day that it's always part of the psychiatry curriculum in residency training, because it can be so useful. And a client sits down and takes it in 30 to 45 minutes on the computer, and you get a computer readout with some pretty solidly good scales that then can help you incorporate more of the complexity of your client in your work. It's a great instrument. I recommend, if you like this kind of approach, I recommend thinking about that and maybe getting training. Psychologists like to think, well, that's only psychologists. That's nonsense. This is a very straightforward instrument that can be learned with quite reliably. In fact, at Bronx Lebanon Psychiatry Department, every psychiatrist comes out of the Bronx Lebanon residency with competency in the PAI. So we know it can be done. So, and then the Milan Clinical Multi-Axial Inventory is a pretty popular instrument, but it has, and you can see it has a lot of hits, but you take a look at the number of peer-reviewed hits. It's substantially less. The PAI, which is a relatively new instrument comparatively, already has over 1,500 peer-reviewed articles. The research on that is coming along quite nicely. The problem with the MMPI has 567 items. Personality assessment inventory has 344 items, but you get 4 choices. Instead of true, false on the MMPI, you get, symptom doesn't apply, sometimes, mainly. So what it does is by using a different scaling, you're doubling the hits that you get. The Milan is 175 items. Its biggest problem is you really have to know this instrument really well to know what you get. So for instance, one of the things I like to do is to talk about somebody who comes up with a profile that is narcissistic, histrionic, and compulsive. What? It's a weird set of collections. Well, if you give that to custody litigants who don't have a history of mental disorder, this is what they score, because it's a variant of having high desirability because of the overlap of scales. And you just don't want to get on in a situation where you're saying, well, you know, I have this parent who is both narcissistic compulsive and histrionic, and they, you know, they shouldn't have their kid or something like that, or something part of the data. And to find out that that's what the normal response is for custody litigants, it's a bad moment on the stand. So the advantages of these, again, it's evidence-based. It can be used in assessment and monitoring. It's very comprehensive. It has validity scales, really good validity scales. The F scale of the MMPI has higher validity on meta-analysis than X-rays. There's just one comparison. If you want the study, I'll be happy to cite it for you. The Psychotesting has really certain areas of very, very sound validity. And it's easy to administer. And that the reason they were developed was because when somebody came in, they could sit down and take a test, and the clinician can be loaded with a lot of good information early on. The disadvantages are the same disadvantages of all self-report measures. It's more costly, and it's longer, takes more time. It's costly for treatment monitoring. They all require advanced training, and you have to be aware of the reading levels of the person. If somebody has less than about a sixth, really eighth grade reading level, you probably ought not to be giving them an MMPI. PAI has a really genuinely solid fourth grade reading level, which makes it much more applicable, which is why I loved using it in the VA, because that whole issue of reading level, you know, because you're reading this. No presentation from me would be complete without my talking a little bit. You know, we're really starting to go out there, and we're about performance-based measures. It's important to remember that the Rorschach was developed by A, psychiatrist, B, a psychologist, C, a social worker, D, an accountant. Herman Rorschach was, what was his training? Oh, somebody guess. What's that? An artist? Well, that's actually true, but that wasn't one of the four choices, Corey, and that's you again thinking outside the box. But of the four choices, he was an artist as well as a psychiatrist. Worked in inpatient, was really interested in helping, trying to get a clearer sense of the very disturbed patients, institutionalized patients that he had with really severe disorders, and trying to get into the inner world without the whole business. You know, a lot of folks have trouble answering questions. They have trouble responding to people. And so the Rorschach inkblot method was developed as a way to deal with that. Rorschach himself had a scoring system, and he really believed in the use of it. Even though the instrument is very rich clinically, it is grounded, and particularly in the US, where we're so very, very much enamored with science and objective things, which I think is an advantage personally, but there are different points of view about this around the world. And it allows for a measurement of implicit measures, processes not otherwise attainable by self-report. So you could have somebody who is absolutely, has severe thought disorder and poor reality testing, who will not raise on the scale 8 of the MMPI, because the person's either not aware of their problems or they don't want to reveal it. And a Rorschach is the absolutely best measure out there for assessing thought disorder and poor reality testing. If you have a question, maybe this guy's got, you know, gal's got some problems thinking clearly and accurately, Rorschach is a very highly useful test. You know, people talk about the Rorschach being kind of a Ouija board and not very scientifically based. It has over 1,100 hits on Psych Lit, as well as nearly 6,500 peer-reviewed articles. It's a very highly researched instrument, and the current research on it is absolutely fabulous. If you hear the thing where the Rorschach is not valid, how many people have heard Rorschach is not valid? Oh, come on. Is that just me? It's just not valid. You shouldn't use it. It's junk science, right? You heard that? Based on a 2000 article. It's 2017. There have been so much good research and so much debunking of that critique that even those folks are kind of withdrawing the critique. I mean, actually, they did. They wrote a paper in which they removed the moratorium from using it, as if, anyway. Another instrument, which is called the thematic apperception test, it's a storytelling, narrative storytelling test that's really good at assessing self-concept and interpersonal relationships. As you can see, it's very highly researched. It's been around since the 40s. It's a great instrument. It has some problems in that there's not a standardized card set, and there are only recently some really good scoring methods that allow the objective piece. And then there are lots of others, like the adult attachment projective and things like that can be useful. And I'm mentioning these because this is where your local handy-dandy assessment psychologist can come in. If you have a complex case, this is the time to bring out the big guns for psychotesting. It's not around early. You shouldn't be testing everybody. You should be testing one where there's a complexity and somebody's not moving along the way you would think they were, and that you've tried the other assessment-based methods and it's still not working, and you kind of don't know where to go. This is the time to kind of bring out that kind of referral, and where you're using those omnibus measures along with performance-based measures so that you get a very comprehensive view of the person. The advantages, and the testing can be, if you have somebody in a psychiatric hospital who's had multiple hospitalizations, that assessment sometimes can really be, particularly if the person's kind of, rotating in and out of the hospital. This is a time for a psych test, because what's being done isn't working. You may not be able to feel, but you're going to get a better sense of what you can do and can't do by doing that. It also is great for mid-treatment impasses in complex cases, for medically necessary diagnostic clarification and treatment recommendations. It tends to move in a more comprehensive whole-person view. It's much less limited in performance-based issues about self-awareness and response style. These instruments take a lot of training. I trained very hard on this instrument, and I would say that it took me about 9 years, not to be proficient, but to be expert in it. It took me about that amount of time with pretty heavy thing, but it's just been more than well worth it for me. So, in its limited by the difficulty of learning how to administer and score, and there's more significant client face-to-face time, and it's long and costly for treatment. So it becomes a complex case way of trying to break the impasse of what's going on, because it can really be very useful in that way. Let's see, how are we doing? Let's see. So what we can do, I have one more thing that I can talk about, which is called collaborative or therapeutic assessment, which is how many people have ever seen a psych report? A psych assessment report, okay? How many people have read that psych assessment report and felt, huh? A lot, and there really, some of the things are what I call plug and chug, which is the person comes in, they give them a whole bunch of tests, and then they cut and paste from the interpretive reports, and they might have statements, well, the Rorschach shows this shows this, and the statements might be absolutely opposite and not comprehensively intertwined. These reports, in my opinion, are not worth the paper they're printed on. And this is the biggest challenge in the psych assessment world. It's our problem, which is that we need to have greater proficiency and expertise in doing this and try to develop reports that communicate to you and to the client. I don't write reports anymore. I write letters. I write letters to patients that are done in down-to-earth common language, and that, which are harder to do, by the way, than cutting and pasting, but is very much worth the time and energy. And that comes out of this approach to assessment called collaborative assessment. I can go over that. It'd take me about 8 minutes, or we can stop and have a conversation right now about what I've told you so far. Conversation? People have questions, comments?
I'll just share sort of a caveat about using screening instruments routinely in clinic, particularly when they are administered by office staff on the way in, kind of migrating into the record.
Mm-hmm.
There's a medical legal issue that came up repeatedly when I used to do mock depositions with our residents. This is where we would just pull a chart randomly out of the resident's caseload and go through it as if something bad had happened and questions were being asked.
Right.
So picture a situation where the PhD was collected by a secretary and or some other depression-based instrument, and the patient indicated a positive response to a question about suicidal ideation. And then the clinical note that gets generated in the electronic health record makes no mention of that instrument and says SI is negative. How do you reconcile that kind of discrepancy? The point I'm making is that once you generate this data, it creates a duty to make sure that it is integrated in the record and that it doesn't simply go by the wayside, or it can come back to bite you later when there are those kinds of inconsistencies.
Well, there's a reason that it comes back to bite you, because it's suboptimal care. It's sub-basic care. Don't use these instruments if you're not going to interpret them and read them.
Well, I think part of how this happens is when the giving of the instrument and the receipt of the instrument is separated from the clinical relationship done by the office staff. And it just creates the potential for human error in the transmission of the information from one part of the system to the other. Things fall through the cracks.
Well, and I would argue, I agree with you, Tom, and really like to emphasize that. Don't use them if you're not going to use them. And I mean, if you're not going to interpret them. And, it's always better if you have the time to, yeah, go ahead. this goes right to Tom's point, I think. It would, in a medical legal context, if you come in and say, yeah, I gave it and I've never had any training on it, and somehow it is misused or perceived as misused. What's that? Well, the insurance doesn't ask you if you're properly trained. It assumes that you are. The problem is when you use something that you've not read the literature on or read a manual on, and use it or misuse it, and that it becomes a problem, and then it gets into the hands of, yeah, so.